I am Caroline Goodman.
And I'm Elizabeth Turner. We are your acute care speech-language pathologists.
Today we will be introducing you to the hospital-wide swallow safety screening. Our goal is to improve patient care by reducing length of stay, by preventing aspiration pneumonia, and to allow a patient to begin oral intake as soon as possible, once determined to be safe. All stroke patients should be screened for dysphagia before being given any oral intake, including food, fluids, or medications.
Dysphagia is commonly seen in patients who have had an acute neurological event or are acutely ill. Dysphagia is any deficit that affects the oral, pharyngeal, or esophageal phase of the swallow. This can result in aspiration or a variety of other deficits. Dysphagia may be the result of a stroke, head and neck cancer, neurological disorder, head trauma, cognitive deficits, diffuse weakness, or other disorders. It is the role of the speech-language pathologist to evaluate and manage dysphagia in the acute care setting. The nurses and speech-language pathologists will work together to ensure safety with oral intake with each patient. Every patient who is admitted will be asked a series of questions to assess aspiration risk. If appropriate, screenings may be completed.
Did you know that 27 to 50% of stroke patients develop dysphagia? 43 to 54% of stroke patients with dysphagia will experience aspiration. Of those patients, 37% will develop pneumonia. 3.8% with pneumonia will die if not part of a dysphagia diagnosis and treatment program. Other adverse effects of dysphagia include malnutrition and increased length of hospital stay. Dysphagia may also affect not just the health of the patient, but their quality of life.
Dysphagia may include silent aspiration and may therefore be difficult to diagnose at the bedside. Silent aspiration is defined as entry of food or liquid below the vocal folds without a cough or visible symptom. Research has shown that silent aspiration occurs in 40 to 67% of acute stroke patients. Silent aspiration is only identified by completing a video fluoroscopic swallow study, which is completed by a speech-language pathologist.
The swallow safety screening is designed to assess for signs and symptoms of aspiration with oral intake. Common signs and symptoms of aspiration include coughing, wet gurgly vocal quality, throat clearing, and shortness of breath. You may observe these signs or symptoms on your patient before, during, or following oral intake. Please remember, aspiration can occur without any visible signs or symptoms. A recent study with 2,000 patients revealed 51% aspirated on the video fluoroscopic swallow evaluation. Of the patients who aspirated, 55% had no protective cough reflex, which is known as silent aspiration. The diagnostic pathology groups with the highest rates of silent aspiration were brain cancer, brainstem stroke, head and neck cancer, pneumonia, dementia, Alzheimer's, chronic obstructive lung disease, seizures, myocardial infarcts, neurodegenerative pathologies, right hemisphere stroke, closed head injury, and left hemisphere stroke.
With each new admission, the nurse will answer a series of questions to determine aspiration risk. Each question is weighted based on severity. Responses to each question are scored from 1 to 5. If the total score is 5 or higher, the patient is deemed at high risk for aspiration and should be kept NPO, including medications, until evaluation by a speech-language pathologist is completed. An order for a bedside swallow evaluation with speech-language pathology will automatically be generated in Meditech. The speech-language pathologist has 24 hours to complete the bedside swallow evaluation. If a patient scores lower than 5, the nurse will proceed with the swallow safety screening. Step-by-step directions will be available in Meditech. Prior to initiating the swallow screening, you should be sure the patient is fully awake. If the patient is not awake, you should return to reattempt the screen when the patient is more alert. The patient should not automatically fail the screen due to reduced arousal. Sit the patient upright as close to 90 degrees as possible. Do not feed the patient if they are not sitting up to at least 45 degrees. Ensure the patient can follow commands. Please note, patients with aphasia should still complete the screening even though they may have receptive language deficits. The patient should be able to cough on command. Ensure the patient's oral cavity is clear of foreign objects before giving them any oral intake.
Begin the screening by giving the patient 1 teaspoonful or 5 cc's of water. Observe for the following: absent swallow response, check for elevation of the patient's Adam's apple, wet or gurgly vocal quality, have the patient say ah, cough or throat clearing before, during, or after the swallow. Note that this response may be delayed. Shortness of breath, spillage from the lips, pocketing or holding fluid or food in the mouth. If the patient demonstrates any of these signs or symptoms, discontinue the screening immediately. Keep the patient NPO until a bedside swallow evaluation is completed by a speech-language pathologist. Your answers to the screening questions in MEDITECH will automatically generate a referral to speech-language pathology. If these signs or symptoms are not observed, proceed to the next portion.
Have the patient take a sip of water from a cup. Do not use a straw or syringe. If possible, have the patient hold the cup independently. Observe for the following: absent swallow response. Check for elevation of the patient's Adam's apple. Wet or gurgly vocal quality. Have the patient say ah. Cough or throat clearing before, during, or after the swallow. Note that this response may be delayed. Shortness of breath, spillage from the lips, pocketing or holding fluid or food in the mouth. If the patient demonstrates any of these signs or symptoms, discontinue the screening immediately. Keep the patient NPO until a bedside swallow evaluation is completed by a speech-language pathologist. Your answers to the screening questions in MEDITECH will automatically generate a referral to speech. If these signs or symptoms are not observed, proceed to the next portion.
Have the patient drink 3 to 4 ounces of water from a cup. This is equivalent to about half of an 8-ounce cup. If possible, have the patient hold the cup independently. Do not use a straw or syringe. Observe for the following: absent swallow response, check for elevation of the patient's Adam's apple, wet or gurgly vocal quality, have the patient say ah, cough or throat clearing before, during, or after the swallow. Note that this response may be delayed. Shortness of breath, spillage from the lips, pocketing or holding fluid or food in the mouth. If the patient demonstrates any of these signs or symptoms, discontinue the screening immediately. Keep the patient NPO until a bedside swallow evaluation is completed by a speech-language pathologist. Your answers to the screening questions in MEDITECH will automatically generate a referral to speech-language pathology. If these symptoms are not observed, proceed to the next portion.
Have the patient eat 1 gram or saltine cracker. Observe for the following: absent swallow response. Check for elevation of the patient's Adam's apple. Wet or gurgly vocal quality. Have the patient say ah. Cough or throat clearing before, during, or after the swallow. Note that this response may be delayed. Shortness of breath, spillage from the lips, pocketing or holding fluid or food in the mouth. If the patient demonstrates any of these signs or symptoms, discontinue the screening immediately. Keep the patient NPO until a bedside swallow evaluation is completed by a speech-language pathologist. Your answers to the screening questions in MEDITECH will automatically generate a referral to speech. Please note, many of our patients do not have teeth or wear dentures. This is not considered dysphagia. If a patient passes the swallow safety screening and is edentulous, he or she should be placed on a pureed diet. After the patient passes the swallow safety screening, the physician may initiate oral intake. The patient may begin a pureed, mechanical soft, or regular diet.
If the patient requires a bedside swallow evaluation, the speech-language pathologist will complete a comprehensive assessment of swallow functioning and safety. If required, the speech-language pathologist may recommend a video fluoroscopic swallow study to examine the physiology of the swallow. In a video fluoroscopic swallow study, or VFSS, the patient swallows a variety of liquids and foods mixed with a barium contrast as a video X-ray is taken of the oral cavity, pharynx, and esophagus. This procedure allows the speech-language pathologist to view the passage of food and liquid from the mouth, through the throat, and into the esophagus. It may also reveal aspiration should foreign material enter the airway. The video fluoroscopic swallow study is the only way to identify silent aspiration.
The speech-language pathologist will attempt a variety of compensatory strategies and maneuvers as appropriate to prevent further aspiration during the video fluoroscopic swallow study. The speech-language pathologist may recommend diet modifications, positioning, and dysphagia therapy depending on the physiological cause of the swallowing deficit. Diet modification may include the use of thickened liquids. It is important to know whether your patient is recommended to receive nectar versus honey-thick liquids. These are carefully recommended based on the patient's performance during the video fluoroscopic swallow study. Pre-thickened liquids can be ordered from the kitchen for patient's use.
A research study performed in 1991 showed that treatment of dysphagia consisting only of changes in posture and diet resulted in more than 80% of patients resuming a full oral diet with no incidence of pulmonary or nutritional complications. Following a bedside swallow evaluation or video fluoroscopic swallow study, the speech-language pathologist will post a swallowing precautions sign at bedside tailored to the specific needs of that patient.
Oral care plays an important role in preventing aspiration pneumonia. Research has shown a link between poor oral health and the development of pulmonary disease in high-risk populations. The mouth and throat contain a vast number of microorganisms. Aspiration of oral and pharyngeal secretions containing these infectious organisms is a leading cause of aspiration pneumonia. One study showed that improving oral hygiene reduced the incidence of nosocomial pneumonia in non-intubated patients by an average of 40%. Please remember, if your patient has dysphagia, oral hygiene is an important step in preventing respiratory complications associated with aspiration. Completing the swallow safety screening will ensure patient safety, decrease length of stay, and increase patient satisfaction. Each nurse plays a critical role in preventing aspiration pneumonia.
Please call Speech-Language Pathology with any questions.